Hello everybody. Today we're going to do an overview on stuttering, and my name is Julie Baker. I'm a graduate student at Marshall University and I'm studying speech-language pathology.
And my name is Craig Coleman. I'm a faculty member at Marshall University and a board specialist in fluency disorders.
To begin with, it's important to define what fluency is to compare it to what stuttering is. And so fluency is basically a smooth, forward-flowing speech, and you're going to have appropriate pitch, rate, effort, and it's basically what all of us, or the majority of us, what we do. But most of us also have disfluencies in our speech, and a disfluency, just to define that, is going to be some kind of a disruption in the forward flow of speech. And there's several different types of disfluencies that you can have. And specifically, there's repetitions, prolongations, blocks, interjections, and revisions. And a repetition would be like when you repeat a sound, such as, can I go to the mall today? And at that, I repeated the k sound in can. A prolongation would be if you stretch out a sound like, maybe I can today. And then I stretched out that sound. And a block would just be when you completely get stuck and you just, no sound is coming out. And interjection, all of us do that. We have words like or just like I did right there in speech. And then a revision would be where you kind of start over. You make an error and then you repeat maybe like a phrase or a word.
So while disfluency is just a disruption in the forward flow of speech, stuttering is a little bit different. Stuttering includes a disruption in the forward flow of speech that can take many forms, such as the different types that Julie just told you about. But stuttering is much broader than that in that it could include things such as physical tension, where you see a lot of strain and effort on the part of the speaker as they're talking. Secondary behaviors where they might blink their eyes, move their head, tap their hand, move their foot. Stuttering also usually encompasses some negative thoughts and emotions on the part of the speaker, and you might see some negative reactions to stuttering or to talking in general. And most importantly, you may see some decreased communication skills. Now, not all people who stutter have decreased communication skills. Some people who stutter are still very good at communicating. I think the message that we want to try to send today is that you can still be a good communicator if you stutter. That's just one aspect of it, but we want to give you some things to look for in terms of making sure that a child who stutters is still communicating effectively with their peers and with other people. When we look at stuttering, we can break it down into core behaviors and secondary behaviors. So core behaviors we consider to be involuntary. These things happen at the level of the neurological system. So when we see different types of disfluency, such as repetitions, prolongations, blocks, Julie gave you examples earlier of what those might sound like. When we see those different types, those aren't conscious decisions that the speaker makes. They happen involuntarily at the neurological level, so changing them is very difficult. Secondary behaviors are much different than that. Secondary behaviors happen as a result of negative reaction to stuttering. So they are essentially learned reactions where people might have physical tension, have those hand, eye, head, feet movements associated with stuttering. Secondary behaviors arise as a result and a response to stuttering. So if I'm having a disfluent moment and I go like that and I really try to force out the sound, I add a lot of physical tension there and I do things with my head or my face to try to push out the word. That results from trying to get the word out so hard that I'm really trying my best to push it out effortfully. And so the secondary behaviors are a bit of a learned reaction that we can target in therapy.
Regarding prevalence, and that's going to refer to how many people in the current population stutter. About 1% of the adult population stutters. But as far as incidence goes, and that's how many people have stuttered at some point in their life, that's approximately 5%. There's also a difference in stuttering depending on your gender, and in general, stuttering is going to affect more boys than it does girls. And in adults, the ratio is about 4 to 1, as versus children, the ratio is closer to 2 to 1. So really that suggests that men are more at risk for continuing to stutter than females are.
In most cases, stuttering will typically develop between the ages of 2 and 5. About 95% of kids who start to stutter do so before the age of 4. So an onset after 5 is pretty uncommon, but it does happen every once in a while in a small percentage of the population. A lot of times initially in children there's a lot of fluctuation in their fluency at the early ages, and that makes it very difficult sometimes for parents to determine if a formal evaluation is needed. So if you look at a young child when they're starting to develop stuttering, they may have periods of increased fluency and they may have periods of increased stuttering. And so when they go through those periods, it makes it difficult for parents to fully understand whether or not they need a speech and language evaluation. For those kids who do start to stutter after the age of 5, we know that they are at much greater risk for continued stuttering than someone who starts at the age of 2.
In terms of who stutters, it's really not particular to any culture or race. Stuttering has existed in all cultures and races, and we even have evidence that people stuttered as many as 40 centuries ago. So it's not a new thing, and it's something that's certainly not particular to any one culture or race.
Theories of stuttering have evolved a lot over the past 20 or 30 years or so. Many years ago, stuttering was seen as a psychological disorder. Even going back to the Freud era, people saw it as fulfilling a repressed need or a psychosexual disorder. Then we moved into more of a learning theory where people thought that stuttering was a learned behavior. The diagnosogenic theory was very popular for a long time, where people thought that if you labeled stuttering or you talked about stuttering with a child, that would essentially doom them to a life of stuttering. We know that those theories are outdated at this point. They're not true anymore. Stuttering was also thought to maybe be related to anticipatory struggle, where if you anticipated that something would be hard for you to say, that you would stutter as a response to it. And going back to the learning behavior, there was a lot of classical and operant conditioning involved in that. Where we are now, though, is we see stuttering as a multifactorial disorder that has a lot of different components to it, and we see it most importantly as a physiological disorder. So there are genetic components to stuttering. If you have a family member who stutters, you're much more at risk for stuttering. We know it has a neurophysiological component in that if you took a picture of two people, one who stuttered and one who didn't stutter, their brains wouldn't look any different. But if you took that picture while they were actually talking, you would probably see a little bit more activity in the speech processing areas of people who stutter. So you see that heightened linguistic processing and temporal processing in people who stutter, and they tend to have some difficulty with that as a result. We also know that demands and capacities figure into the equation a little bit. Every person has a capacity for being fluent. The more demand we put into the situation, the more likely it is that somebody is going to stutter. For a person who doesn't have a predisposition to stuttering, you can put almost as much demand as you want into the situation and it won't make them stutter. But for somebody who does have a predisposition to stuttering, things like being tired, being sick, using a higher vocabulary, using longer, more complex sentences, talking really quickly, being really excited, all can contribute to situations where they might stutter a little bit more. Now, we don't want to avoid those situations, but we just want to understand that they might contribute to them being a little bit more disfluent. In terms of the genetics, we know from numerous studies that have been done to this point that genetics play a strong role in stuttering. If you are a person who stutters, you're about 67 to 70% more likely to have another family member who stutters than somebody who does not stutter, than a person who doesn't stutter. So we're starting to be able to identify those genetic links, and we know that the genetic risk is there. What we don't have enough information on yet is what specific gene is consistently altered or if there's a genetic component for everyone. Even if we say that 70% of people who stutter have some genetic component, that still leaves us with 30% who don't. So we know that there's going back to the multifactorial model, there's a number of different factors that come together, and there's an interaction between genetics and environment.
When it comes to stuttering, there are myths that people hold, so it's important to dispel some of those myths. One of those being that environment, some people might think that an environment contributes to stuttering more than another environment. And so just to clarify, stuttering, it's not necessarily any more prevalent in children who grow up in an abusive or a neglectful home, but that's not to say that the environment can't impact their reactions. And so a reaction is a different idea than what causes stuttering. And so Craig's going to have an allergies analogy that he's going to talk about.
If you look at kids who have allergies, it's a really good analogy for kids who stutter in terms of some of the environmental ramifications, because if we look at allergies, taking a kid out in pollen, around trees, fresh cut grass doesn't make them allergic to those things. Taking a kid who's already allergic to those things out in that environment will tend to make it a little bit worse, though. And so, having a kid in a negative environment is not going to cause them to stutter. But having a child who already stutters in a negative environment is probably going to cause the reactions to be stronger and may exacerbate the disorder a little bit.
Another myth that persists about stuttering is that stuttering is caused by being nervous or anxious, and that's not true. Stuttering is not caused by being nervous or anxious, but once again, certain personality characteristics can alter how a child responds to their stuttering. Like if a child has perfectionistic tendencies or are highly sensitive, then those can lead to stuttering.
So we may not think of some of these things as things that we want to target in therapy, but they actually are things that we want to work into our therapy activities when we're working with a child who stutters, or if a child who stutters is in our classroom. A child who's a perfectionist, real sensitive, has an intense personality, reacts really strongly to things, very competitive. Again, those things aren't going to make them start to stutter, but what it will cause is they'll cause the reactions to stuttering to be much stronger, because kids who have those personality characteristics tend to like to do things very well. If they can't do things very well, in most cases, they would rather not do them. And so it's important when you're working with kids that have those characteristics to really work on helping them understand that they don't have to do things perfectly all the time, and that they can lose at times, that they can react a little bit less strongly to things, and that still will be okay.
As far as if stuttering can be cured, a lot of children will recover from their dysfluencies on their own, and they don't necessarily have to receive treatment. And treatment outcomes are really great if a child is under the age of 6. But by the age, when they get a little bit older, it's going to be more about managing stuttering and not so much about eliminating stuttering. And then there's 4 types of stuttering that we're going to talk about today. There's cluttering, and then neurogenic, psychogenic, and child onset stuttering.
We look at these different types of stuttering as sort of falling under that umbrella, much like an autism spectrum is an umbrella. Stuttering is an umbrella that has those different types underneath it. One type of stuttering type disorder that we see is cluttering. In cluttering, you see reduced speech intelligibility, meaning that the person has a very hard time being understood by other people due to an increased speaking rate and running together of words. You also see poor organization of thought in a lot of these kids. Cluttering may occur with or without stuttering. And to give you an example of what cluttering may sound like, if somebody's talking really fast and running the words together, a sentence such as, "I went to the store yesterday and bought some milk," might sound like, "I went to the store yesterday and bought some milk." So you see that real fast rate and the running together of words. Somebody who has cluttering that's more related to poor organization of thought, you'll see a lot of filler words in there, a lot of like some phrase repetitions where they're kind of searching around for what to say next. So you see that disorganization come out in their communication. What we see in cluttering is a rapid rate of speech and abnormal phrasing patterns. a lot of maze behaviors, and that essentially means that the content of their message is reduced. So they give you a lot of verbal information, but you can't really decipher a lot of the information because it's not as meaningful. There's no real tension or struggle in cluttering, and that's essentially because the person who clutters doesn't necessarily realize that they clutter that much. So self-monitoring is very difficult for a person who stutters, for a person who clutters, whereas for a person who stutters, they are very aware of their stuttering. In cluttering, you also see frequent repetition of one-syllable words and the first sound or syllable of multisyllabic words. Cluttering appears to be much more related to a learning disability where stuttering is not. Specifically, cluttering seems to be related to a central language disorder. Interestingly, many people who clutter also exhibit learning disorders, and cluttering involves aspects of learning, verbal and written expression, and perception. And what that means is that you are likely to see cluttering. For someone who clutters, you're likely to see that occur in writing as well as in verbal communication. So for a person who goes really fast and runs things together when they're talking, they tend to write the same way, where their writing will kind of be physically mashed together. If they have a disorganization of thought while they're speaking, their writing appears to be very disorganized as well.
The second type we're going to talk about is neurogenic stuttering. As the name implies, neuro, it comes from actual damage to the nervous system itself.
So neurogenic stuttering has several different symptoms that will help you distinguish it from typical childhood onset stuttering. Number one, you see a real high frequency or percentage of words stuttered in neurogenic stuttering, but you see few, if any, secondary behaviors and no real physical tension. So you won't see the hand tapping, the head nodding, the eye blinking. Interestingly, for people who have neurogenic stuttering at times, you see disfluencies in the initial, medial, and final sounds. Most people who have childhood onset stuttering will repeat the first sound just like I did there. People who have neurogenic stuttering might repeat the final part of the word just like I did there on the word might. So you also see disfluencies on content and function words, whereas again with traditional stuttering, you're likely to see it more on the content words. Another interesting point about neurogenic stuttering is you don't see an adaptation effect. And what that means is if you gave somebody a story to read and had them read the story several times over and over again, right back to back, what you would see typically is an adaptation effect where each time they read it, they would get more fluent. For somebody who has neurogenic stuttering, you won't see that, and they'll continue to stutter as much, if not more, on each successive reading. You also see in neurogenic stuttering that the speaker is not typically very anxious or concerned about their speech.
As far as the etiology or the cause of neurogenic stuttering, it's going to follow something like a stroke or some other kind of brain trauma, maybe surgery, drug use. And then with any kind of injury like that, it's not necessarily always going to happen in the left hemisphere of the brain or always the right hemisphere. It just depends on where the injury actually happens. So it could be one of the hemispheres or it could be both depending on the injury. Psychogenic stuttering is the third type we're going to talk about. And that is going to be stuttering that's associated with a psychological disorder of some type.
Some of the symptoms you might see in psychogenic stuttering, you might see a real sudden onset of stuttering with no previous history of stuttering, and the primary disfluency is rapid initial syllable repetition. And I can give you an example of someone that I treated previously who had psychogenic stuttering, and she would stutter like this. It was very predictable. You could predict almost every word would be, the first sound of the word would be repeated about 5 times on every word. The important distinction of psychogenic stuttering is that you do have a psychological disorder that's causing the stuttering. So this is very different than people who develop some anxieties about speaking, who have childhood onset or developmental stuttering that might develop over time from some negative reactions. In psychogenic stuttering, the stuttering is specifically caused by the related psychological condition.
And then finally, we're going to discuss childhood onset stuttering, and that's the most common type of stuttering. And any adult who stutters, they typically started stuttering when they were a young child.
So some things we want to look here for when to evaluate young children who are stuttering. If a child has a family history of stuttering, because again, that puts them at much higher risk. If the child's been stuttering for more than 6 months, if they exhibit any negative reactions towards stuttering, if they show frustration toward it, or they seem to limit their amount of talking or change words, if they exhibit any physical tension or secondary behaviors associated with their stuttering. Sometimes these can be even very subtle, where you might see slight rises in pitch or loudness to indicate that a child is aware of or exhibiting physical tension with their stuttering. If they have any other speech or language concerns, that would be another indication, as that's another high risk factor. If there's any parental concern, that's another risk factor that we want to be able to address to help educate the parents. And if the child's experiencing negative reactions from any other family members or their peers, that would be another reason why we would want to evaluate those kids. When we look at how we treat stuttering, it's very different depending on the age of the child. As Julie talked about before, for children under the age of 7, so that's 6 and under age, the goal is to eliminate or greatly reduce the stuttering. Once children hit the age of 7 or so, we know that that's probably not going to happen anymore, so our goal at that point shifts to successfully manage the stuttering. So that includes goals to work on educating the patient and the family members about stuttering, as well as those in their community, working to reduce the physical tension and secondary behavior so that talking is not as difficult for them and it's not as much effort or work for them to be able to communicate. Improving the person's reactions to their stuttering so that it doesn't interfere with their ability to participate in life activities. Improving their overall communication so that they can still maintain their social circles and educational opportunities as well as anybody else. And lastly, and probably least importantly, is increasing their speech fluency. What we see with working with most kids and adults who stutter is that the number of disfluencies they have is really the least important part of stuttering. All of those other things above it are much bigger factors.
In terms of therapy, it has evolved throughout the years. Prior therapy, when we first started treating stuttering, was likely as more clinician directed, which means it's going to look less natural. It's going to be very structured. And in general, it might not carry over what you do in treatment because it doesn't reflect anything that the child ever does other than in the therapy room itself with that particular clinician. And since then, we've gradually moved to centering treatment more around the client, so it looks a little bit more naturalistic than looking at the client in the context of their family and who they're going to be around, to finally looking at treatment and the client in the context of not just their family, but their community that they might be interacting in as well, which could include something like the school, if they're a school-age child, the workplace. So therapy, ultimately, we try not to conduct it in a way that's not natural, but conduct it in a way that it looks like how they might interact in the real world that they live in and carry over better and generalize better.
So if we think about what community-centered therapy is, it really helps focus on all aspects of the stuttering disorder, the affective, the behavioral, and the cognitive. The affective indicates to us what the feelings and emotions are associated with stuttering. The cognitive is the thought process that's associated with stuttering, and the behavioral is the surface level characteristics that we actually see. So to give an example of that, if you have a person who is going to order food at McDonald's, let's say, and they're sitting in line at the drive-thru, and as they're waiting in line at the drive-thru, they feel really nervous, really anxious, really upset about the fact that they have to order their food because they might stutter. Then when they go to order their food, they say, "I want a hamburger." So we saw the affective component there with the negative feelings, negative thoughts, negative emotions going in, feeling nervous, feeling anxious, upset. We saw the behavioral component because we saw the block and trying to get the word cheeseburger out, but just couldn't do it, the stuttering in that moment. And then we saw the cognitive component and the conscious decision to change the word cheeseburger to hamburger because they felt like they couldn't say cheeseburger. Now, if you look at what impacts a person's life the most, it's the behavioral component that affects them the least. So the affective and the cognitive component of that situation really affect the person more than the surface level characteristics that we happen to be seeing in that situation. So we look at community-centered therapy in terms of what's the client and the clinician relationship, how well do they get along and interact, is there a mutual sharing of trust and ideas there. We target family and community education about stuttering. Sibling and peer involvement for kids is really critical to the therapy process, involving them in support groups where they can meet other kids who stutter, having the school or the clinic participate in some anti-bullying programs so that people can learn how to react to individual differences, and even doing things like teletherapy where you can get into the person's home to work on treating some of this rather than just doing it in a clinical setting.
Like we talked about earlier, most people who stutter, they start stuttering when they're children. So it's important to think about the school experience, considering that most kids are in school. And in general, research is indicating that a lot of children who stutter, they've had a negative school experience, and it has impacted their educational opportunities, both as a child and as an adult. And also their social interactions have been affected. They may be more prone to be bullied when they're in school, the negative reactions that people have to their stuttering. And so all of that is going to impact them not only as a child, but as an adult. So it's important then to look for avoidance behaviors, especially in the child who stutters, to try to notice that they could potentially be stuttering and then refer them for treatment to help both their educational outcomes and then their social outcomes. And some children who stutter and people who stutter, they may remain silent rather than stutter, and so that might give the appearance that they're shy, but maybe they're really not shy. It's just they choose sometimes to remain silent rather than let others know that they stutter. And they may, kind of going into this too, have interactions that they just avoid if they have to speak. Maybe they don't want to do a public presentation or a speech in the classroom or something because they know that they might stutter, so they could actively avoid that or avoid talking to people at recess. And all those things are going to reduce overall interactions with other people, and then that's going to impact their social experiences that they have. So it's important to look for those kinds of red flags that a child might be exhibiting. Sometimes they avoid words, like Craig used the example earlier. If they can't say cheeseburger, they might just replace it with hamburger because it's easier to say. And that's important to look for because it's not really what they wanted. They didn't want the hamburger, they wanted the cheeseburger. So it's important that they say what they mean. They might use fillers excessively, like, etc. They might not make eye contact sometimes, or if they're experiencing a block, they might be pretending to stop and think rather than just go on and push through the block. And sometimes they might have those secondary characteristics where they're going to be moving a lot or moving their foot or their hand while they're speaking to try to, what they believe at least, to help them through a stutter. So those are some things to watch for. Also, too, as far as what you can do, if you're in the classroom teaching or if you're working with a child who stutters, or just in general, if you know somebody who you think might stutter, you can slow down your own rate of speech. And in the situation where you know that the child stutters and you've talked about it, you can point out that every fluent speaker has disfluencies in their speech too. So it's not like anybody has completely fluent, perfect speech. And it's really important to not give children instructions when they're speaking and tell them to slow down and do those types of things, because then it might convey the message that you're listening more to their speaking and their stuttering as versus what they're actually saying, which is what the next point says there is it's important to convey to them that you care about what they're saying and you care about them as a person rather than their stutter. Another thing that's really important to do is maintain eye contact when somebody's stuttering. And other studies have shown that sometimes that's difficult for individuals to maintain that eye contact. And but it's important to do that because that's what we do generally when we're speaking to fluent speakers. And always allow the person time to finish speaking. Don't interrupt them. Don't fill in words for them. Just let them talk like you would anybody else. And then ultimately then just treat a person who stutters like you do anybody else.
So some things you want to also avoid doing, as Julie said, you don't want to tell children to slow down. Most people, that's their first reaction when they hear a child stutter. But in most cases, people don't say that at all based on rate of speech. They say it whether or not the child is stuttering. So the message that gets sent is not really to slow down. The message that gets sent is don't stutter. It's also not a good idea to tell children to think about what you want to say before you talk. In most cases, people who stutter think about what they want to say far more than people who don't stutter because they're trying to plan out what they want to say, what they might say if they stutter, a third option if the first two don't work. So they do think about what they want to say and usually more than anybody else does. It's also not a good idea to tell children if you just use your speech tools all the time or if you just use your strategies more. The the good example of this that I would just kind of offer to you is that imagine for a minute that your assignment was that you had to go out and for a full weekend you had to stutter on purpose on every sentence that you said. You could do that for probably about 20 minutes or so, and then it would become exhausting and you wouldn't either want to talk anymore or you would choose not to do the assignment anymore. And so for somebody who stutters, their natural way of talking is to speak with some disfluencies in their speech. Having to constantly think about and override that system and change it requires an enormous amount of work and effort. Sometimes they don't want to do that, and that's okay. They just want to talk, and we need to be okay with the fact that sometimes they're going to talk and sometimes they're going to stutter.
Finally, here's some resources that you can check out that will have more information. The first one is Marshall University Stuttering Research and Treatment Program, the National Stuttering Association, the Stuttering Foundation of America, Stuttering homepage. All of those have additional resources that you can check out if you're interested in finding out more information. Thanks for listening to our presentation.